Welcome to Deciphering Growth, the show that explores mental health from every angle. We bring you conversations with personal opinions, stories, and practical tips. We aim to break down the stigma and help you live your best life. So please sit back and let's dive in. Before we begin, we want to remind our listeners that this podcast represents the opinions of Tiffany Graves, Eric Stone, and the show's guests. The content provided is for informational purposes only and should not be considered medical advice. Please consult a healthcare professional for any medical questions. The views and opinions expressed are our own and do not represent those of our workplaces. Listening, reading, emailing, or interacting on social media with our content does not establish a doctor-patient relationship.
All right, guys, we are here with Hannah and, of course, Eric. Hannah, why don't you introduce yourself? Tell us a little bit about yourself and kind of the reason we brought you here.
Yeah, well, thank you so much for having me. I'm Hannah Smith. I'm a therapist located in the Kenwood area. I specialize in treating women's health through all stages of life, but particularly in the perinatal experience and parenting. And I treat through EMDR intensive. So in days of intensive therapy that really allows people to kind of work on the things that have impacted them from childhood and may now be impacting their parenting experience or their perinatal experience.
Wow. We are so excited to have you on, Hannah. We were just talking off mic before we started recording just about how this is such a needed area of expertise that Tiffany and I have had a few clients in this area. And so we're really excited just to have you. I think I have a question for you just right out of the gate, because I noticed you are not just someone that's taken a few trainings, like you are someone that has like a whole other like certifications. So I was gonna, and I may even mess it up because like I didn't practice it, but I looked it up yesterday. It was interesting. What is a PMHC like
Yeah.
certification? So if I'm looking online, like what is that? Because I don't know if our listeners would know what that is. I will check myself. I did
I
not
don't know if I know what
yesterday.
that is.
Yeah, it's a growing area of expertise, and it's from Postpartum Support International, which is like the leading organization in the world that supports women during the perinatal experience. And they offer this PMHC, which is a perinatal mental health certification, which it requires like, I think it's now it's a little bit harder to remember, but like 20 hours
Mhm.
of in-depth training, 2 years of post-grad experience in the birth experience, like birth world or perinatal world, and a certification exam. So similar to like the LPCC exam, or I mean, like the fancy exam we all have to go and take where we're like sitting. I
Mhm.
had to take another one of those for this certification. And
Wow.
it really, I got into the PMHC world when I was 8 months postpartum, and I already had my master's degree, and I was already practicing. And I felt like I literally knew, I wish I had had it before, because there were so many experiences I had that I felt so validated by when I'm learning about this. I'm like, oh my gosh, I'm a mental health professional. I had no idea this was a normal thing or like a typical thing that happens during the birth process or the pregnancy process. And I really was like, oh my gosh, this is such an enlightening area of our field that just really isn't like highlighted nearly enough.
Mhm. That's so helpful. I just thought one takeaway I wanted to make sure is if someone is looking for that expertise and they see that PMHC credential, like that means
Yeah.
that is what Hannah's talking about. And so
Yeah.
that's one of the things Tiffany and I will roast on the podcast is sometimes people say they have expertise in everything. Like that is certainly expert quality when you've gotten a certification in something and have that ability to advertise that. But Tiffany, I know you've prepped a lot, and I mean, we both did, but I don't want to steal your questions because I usually do that. So I'm just calling myself out that Tiffany makes these great questions and I steal them. So Tiffany, I want you to get the chance to ask your great questions.
Yeah, I guess the first question I would have for you is kind of like, what are some common experiences or practices in women's healthcare that can lead to feelings of trauma, especially those for those dealing with infertility.
Yeah, so if it's okay with both of you, I'd like to sort of take a step back and set the like stage of how the mental health and the physical health system was formed for women, because I think it provides a lot more context for the traumatic experiences, and that it's not necessarily doctor patient, like it's not a bad doctor doing something to a patient, but it's the system that doesn't take into account the needs of women. So looking through a historical context, the last lobotomy on a woman was performed in 1967, which is like in my parents' lifetime, right? Like that is a
Yeah.
very fairly recent, like common practice that women were labeled as hysterical for having emotions, for speaking up for their needs, and were often put in psychiatric asylums. Like up until the mid 20th century, women could be put in an asylum simply for like defying their husband or their father. So this is really like it gives us a lot of context for the way women are believed, the way women are treated. Through the 1970s, so 1977, the Food and Drug Administration ruled that women of childbearing age should be excluded from all phase 1 and phase 2 clinical trials because they were too complex because of hormonal systems. So that was overturned in like 1986, I believe, but that was 10 years of when women were like not included in trials. And that really impacts the way that we know women are impacted by drugs, by procedures, all of these things. And while now we say that like women are included, I think it's sort of, it may not be as formalized, but there's some informal processes that women are excluded through. So like I was listening to another podcast the other day on GLP-1s, which are like Ozempic, Wegovy, all of those new medications. And in the phase 1 and phase 2 trials of Ozempic, women of childbearing age who were not on, I think they said like highly effective form of birth control were excluded from the trials. So like, and there's a reason for that. I think and I don't know what the way around that is, but it's important to recognize that like a lot of the medical knowledge we have to date doesn't take into account women's bodies and women's needs. Like this is, and forced sterilization happened as late as the 2010s and for incarcerated women in California. Roe v. Wade was overturned in 2022. We're hearing all this horrific news about the maternal mortality rate, which is rising, and women dying because of these concerns. So like when we look at the interactions that's happening between a singular patient and a doctor, all of this context comes into play, right? Like what Kamala Harris says, do you think you fell out of a coconut tree? You exist in the context of all it has come before you. Just really recognizing like all of those interactions, the way women have been seen throughout time, what we know about women come into play in this like singular interaction with a doctor and a patient. So what we do know is that like women's pain when they report it to a doctor and their symptoms tend to be minimized. And this is seen from the ED to the PCP, right? Like when you go to an emergency room, women are more likely to wait. They wait 29% longer to be evaluated for heart attacks when they present with chest pain. We know that women who report having symptoms of like, I'm having pain with periods, I'm having pain with sex. I've had so many clients sit in front of me who tell me about this and their doctors say, that's weird. I don't like, let's get you on birth control. It's very, very minimized. It's sort of like, well, we don't really know what's going on with that. And rather than digging, we're just going to try to find a solution to the symptom without digging deeper. PCOS, which is polycystic ovarian syndrome, impacts up to 18% of women, which is wild. Almost 1 in 5. More conservative estimates say like 5 to 12%. And there are no FDA approved medications or courses of treatment for that. So like recognizing that when a woman sits down and they say like, I'm having pain, I'm having weight gain, I'm having, irregular periods, a lot of doctors, one, don't really know how to diagnose some of these conditions. And then two, we don't have the knowledge about like, how do we treat it? So often doctors, and not because of being a bad person or a bad doctor, but just because they have like a lack of knowledge, sort of dismiss this, and we recognize that there's a lot of implicit bias about women, and then we add in any sort of intersectionality of like race or body size or sexual orientation or gender identity, and it just amplifies more and more and more. So I just ranted for a while because I can talk about this
No,
for a while, but what questions do you all have about that or anything I can clarify?
that's a beautiful context. I want to make sure I'm listening, so I'm not mansplaining this today. So I appreciate the context. I love that it's zoomed out even before, and I really appreciate the nuance of that take, that it's not bad doctors, it's a bad system, and the system promotes these interactions. But I want to make sure I'm going to probably take a more of a collaborator backseat today, Tiffany, so you guys can have the lead on this discussion. But Tiffany, anything you want to kind of steer that towards?
Um, I think it's just, as Hannah mentioned, important to know the background. Like there were many things that you were talking about where I'm like, yeah, I've unfortunately experienced that in the medical field, and I think the one that frustrates me the most of like, oh, your numbers are on paper, you're fine, and it's like, oh God, can't you just like listen to a person? Um,
Right.
yeah, and I guess like knowing the way the system like has been created, like, what ways do, your clients come to you and talk to you about like those feelings of being traumatized in the medical field? And I can only imagine like the raw emotions you work with when it comes to like infertility in the medical field, because I know like there's some doctors, not to shade anyone, who like don't believe in vitro and like have very staunch opinions.
Yeah. I personally think there is a little bit of shame there when you're like talking about providers who are there to serve their patients and then put some moral emphasis on things like lack of access to birth control and IVF, things like that. Like it is really hard to say like for me that like, oh, that's, I think it does impact. And I think that that's important to realize, especially in Cincinnati. We have a very moralized healthcare system. We have Christ, Jewish, Mercy, and then I mean,
Good
those are the
point.
three major, and then St. Elizabeth and like they are very,
That's a
very,
really good point. I've never heard it said that way. Sorry. That's a
yeah,
very good point.
they are very religious organizations. And like, um, like this is a pre-Obamacare, which for so many women was a saving grace. But when I was in my early 20s and I was under my parents' health care and my parents worked for one of those systems, I wasn't able to be prescribed birth control because they were able to say we don't feel morally comfortable with providing that. So recognizing the way providers are like the way that these systems are interacting can be very, very shaming for women. Um, you know, I also think it's important to recognize, especially when we're talking about infertility, that in Cincinnati and in other county or in other large cities in Ohio, there's often a lack of voice, choice, and control in providers, like who you can go to. In Cincinnati, we have one large infertility provider. So let's say it's, someone has had a bad experience with that provider, or they experienced a loss in that provider's office and they're re-triggered every time they go in, or a medical professional was not empathetic or kind, and they really just want to be away from that environment, which is what a therapist, so many of us would talk to our clients about, is like getting away from environments that make us like invalidate us and make us feel less than. If you want to have a baby and you're dealing with this infertility, often you don't have a choice if you want to continue to go through the system. So many people, I think that's important to recognize that a lot of people do not have that voice, choice, and control that is so important for making people feel empowered.
So I'm hearing that some people are literally having to face with like re-traumatizing themselves so that they can pursue the dream of wow.
Yes, I mean,
Wow.
and I've encountered a lot that I think so much of this comes from compassion fatigue in providers as well, where if you have an office where all they're treating is infertility day in, day out, I imagine for providers that has to be so exhausting. And all of those big feelings that women are rightfully having and their partners are rightfully having can also feel exhausting. And that is a really hard reality where both people are entitled to their feelings and also there is a power dynamic, right? These providers are in control of women's care. So I've had many, many infertility clients who are calling their providers frequently because they've experienced they've experienced loss in the past, or they're, they're in the early stages of pregnancy and they're so worried and they're so anxious, and they get really dismissive answers, or they get really dismissive care. And it can feel just so, especially depending on previous trauma, it can feel so invalidating of like, I'm too much, my needs don't matter, my emotions are too much, when that's really not the case. Like, you're allowed to have big feelings when you're terrified of losing your pregnancy, or that your treatment didn't work, that you also paid a ton of money for, which money is a big element of this as well, because what makes people feel safer than having money, right? And having financial security. And then when you're going into an office and spending $1,000, $1,500 per IUI cycle, or way more for IVF, it's like it's putting these two things together. Like, medical systems don't feel safe, and also spending this money doesn't feel safe. And then it's like putting all of that insecurity and vulnerability right out in the open.
Wow. I just following up on some of the stuff you're
Yeah.
saying with that, like, it would seem like it would benefit both the healthcare systems and the patients if there was like maybe a set of trauma-informed protocols. I'm sure that that is somewhere in the patient's medical history. Like, are you aware of any such protocols, or some providers doing it better of handling with trauma-informed perspectives?
Yeah, so some providers are doing it better. And I found that for a lot of providers, it's really based on individual seeking out the research and finding out more information. Also, and I do think it's important to recognize that female doctors have better outcomes. So, like, we know that being treated by a woman in any area of health, you're more likely to have a better outcome. So I think it's important to recognize that when we lead with humility and recognizing the elements of like what's showing up in the room, whether it's as a therapist or as a, provider, that our clients are going to have better outcomes. Personally, I had this experience this summer when a doctor said something to me, and it took me a while to figure out why it felt so impactful. And it was because she said, this medication for you, it makes me a little worried. And I couldn't figure out for the longest time. I was like, why did that really stick with me? And I realized it was because I've never heard a doctor use emotion language talking about my care, like that I'm making an impact on their emotional state. And I felt like that was also so like there was so much humility in that statement too, of like, I don't know if this is the best choice for you, but I am being emotionally impacted by it. So I feel like I felt more taken care of, as opposed to often I think what women encounter as well, like in the doctor's office, is this is what you're going to do and you'll be fine. And it's very dismissive, very much like, just get over it. I like this, more, let's be in this together. Let's collaborate together and figure out the best option for you. And a lot of women report feeling way more heard by that. The other thing that I think is it feels so simple as therapists, but just asking for consent. Like, 40% of women, this was just released by Postpartum Support International yesterday, which I think is perfect timing, but 40% of women report being given procedures without their consent, or by being given an explanation of why it was necessary. 40%, like during their medical procedures. So just asking, like, hey, I'm gonna touch your leg now while we do this like procedure. Is that okay with you? Or I need to touch your leg to, be able to access your vulva, whatever it's going to be. Like, just explaining why it's necessary, I think is so important. So many women during birth come to me and feel so like almost made inhuman by this procedure that just used them as a vessel to like get this baby out of them, which I think is also a reflection of our very pro-natalist society, but like in the values that sometimes can show up, but also like really recognizing women have a place in this as well. Women have a place in the birth experience, and it's their birth. So ask for consent to do things, or explain why things are necessary.
Yeah.
Tiffany, I'm going to give this to you. I can't speak from that personal experience with healthcare and the consent piece. So I want to make sure that Tiffany, you get a chance to continue this conversation.
Yeah, I think it's important to recognize, like for women especially, but also for all genders, that like just because you're going to a medical profession doesn't automatically give them permission to just touch, wherever and not explain what's going on. You're in a position of power where like on some level you have more responsibilities to, as Hannah was mentioning, explain what's going on to help people that's not educated in that realm understand.
Yes, 100%. It can feel so invalidating for women when they're not being heard and believed, first of all, and then things are being done to them without their consent. I've had so many women who report going to labor and delivery and being in immense amounts of pain and not being believed that they're in pain. And then they have procedures done without their consent or without them being explained. And it really takes away from this birth experience feeling in their control. Um, and that's extremely traumatizing because it can feel like a life or death situation when they don't have the context for understanding what's going on.
So a question came to mind. I know it's a little off script, from kind of the main points that I had emailed to you, but how impactful do you think it would be to incorporate people doing infertility trauma work that you do into these practices and creating a more holistic approach to women's care?
So I think this is a question that we've looked at in a lot of different systems, whether it's the policing system, the education system. Does it work to like reform the system, or is it like starting from scratch? I truly don't know. And I think I want to be honest with like, I don't know how impactful that would be when there's so many um intrinsic beliefs and like institutionalized beliefs in our systems that really devalue and invalidate women. I do think there would be some positive impact, but would it be the most effective? I don't know. And that's one thing that's really hard about, I think, as therapists, when we interact with any of these systems, it can feel really overwhelming of like, how do we really look for change? But I do know there is really, really important work going on. I know there's people that really do devote their lives to in their careers to making sure that people have more education around trauma-informed care and around consent. So I do think that that's impactful. And I think the more that it starts at like the medical education level, like med school, I think is probably one of the most impactful, like doing that gatekeeping for the medical profession.
Yeah.
Something that kind of comes to mind is like I love the idea of like talking about like touching the body or procedures, but like I also would, this is a question, like what about like even approaching that topic about pregnancy, infertility, even entering into the conversation? Like would that be a best practice of even like asking permission to have that conversation with someone, or what would you recommend?
Yeah, I mean, I think that it would be so wonderful if in our medical system we could have patients set boundaries that are respected and honored, whether it's here are the things that I want to talk about today, like pregnancy, infertility, body size, like those are the topics that I'm coming here for. And then that be honored. I think that would be such an important way, just in the same way that when we have a client come to us and maybe they have 5 things that we can see as therapists that we're like, oh, could all be goals, but they identify the goal and we work with them on that. Really allowing the client to set the tone and like asking, is there anything else that you'd want to talk about today? Is there anything else on the list that we didn't address today? I think could be a really impactful way of um, like allowing provide our patients to take back a lot of ownership of their medical care.
Tiffany, anything? I want to make sure I'm following your lead on this one.
Yeah, no, I mean, I think you're right in line with kind of ultimately the big topic points. Um, I guess something too that we could wrap into this conversation, in what ways can lack of empathy or understanding from healthcare providers amplify feelings of isolation or shame in women navigating that infertility process?
Oh my goodness. It's so rampant. Like I mentioned, if women are calling and like they're so concerned, rightfully so, with the early days of their pregnancy or experiencing symptoms in pregnancy or after their infertility treatments and receiving a response that's devoid of empathy or has minimal empathy, it really can amplify feelings for women of like feeling like too much or too emotional or something is wrong with me. I'm the only one who is having this big of a reaction when we know for sure that is not true. And if like you're spending a lot of money and this is about something that's like the most important thing into your life, it would only make sense that your reactions and your vigilance would be high. So like I think that it's important to also recognize that like so many women leave this system feeling like it's been confirmation that they are too emotional, too much. And there's a lot of internalized beliefs that come with that. So another thing that I think is really important is the way fat phobia shows up in our medical system, specifically for women. I have encountered so many women who have dealt with infertility throughout their, at different stages, and almost every single one has been prescribed weight loss. Like whether they are in a relatively small body or in a larger body, it has been viewed as like, oh, well, your BMI is a little high, which we know that's outdated and it's not really relevant to the conversation, but like women are often prescribed in what feels more shaming in our society than telling a woman that it's a result of her weight and then therefore that it's her fault. Like it's your fault that you can't get pregnant because you are in a larger body or in a body that I don't deem eligible to have a baby. And that is just so invalidating for so many women and feels very much like that something is wrong with me.
One kind of question about advocating for the self as a patient, but it's kind of a two-part question. So one is like, what should a patient themselves be doing to advocate, or what would you suggest? But then I really want to ask about what if someone who comes to be like the advocate with the patient, what would you suggest they do to kind of support the person going through that experience, if you don't mind answering that question?
Yeah, so the first question is about how can the patient themselves advocate, right? And I think so much of that is the work that we do in therapy of exploring these parts of self that are internalizing the blame and shame. So these beliefs of like, I'm not good enough, something's wrong with me. And that's why I'm experiencing all these medical complications. That's why my outcomes aren't good. That's why my birth trauma was so traumatic for me, but because it's something with me. So really exploring those parts of self that are communicating that message. And often what we find is if a client experienced this message earlier in life, like had parents who were really invalidating or who made them feel like they were too much, clients are really quick to jump right back in that neural pathway and be like, I know how to protect myself in this, and it's to believe that I'm not good enough, because I've been doing it for a long time. Or, also parts of self that feel responsible for keeping the peace. Like if you feel uncomfortable with creating a potential conflict with your medical provider, what part of you feels uncomfortable with that? What part of you has learned that the best way to keep the peace is to shove down your own needs, even in an interaction that's supposed to be about you? And so I think recognizing that often these things can be really heightened by childhood experiences because it can be so like reminiscent of the parent relationship. So that's what I feel like is really important. One of the most important things in the sort of a bigger way. And also I ask clients a lot to attune to how their bodies feel before, during, and after appointments. Like what messages is your body giving you about how this interaction felt with your provider? Do you feel calm? Do you feel heard? Do you feel listened to? All of those things, because often women learn to dismiss those feelings of, oh, they said this, but it wasn't that big of a deal, or they probably meant this. Well, yeah, but that's not what they said. So like that's a room for exploration. I think that those are two individual things that people can do to really identify like, is this an environment that feels safe to me? And if it doesn't, next steps might be finding an advocate or doing some outside education to like come equipped more to your appointments to know what things you want to focus on. For an advocate, I don't think an advocate has to be someone necessarily formal, because we know that that can create like financial barriers, things like that. But like this, the journey of infertility often falls so heavily on women in heterosexual cisgender relationships. So really identifying like, this is the mental energy you're spending here. Can you try to share it with your partner? And if you're in a heterosexual relationship, having him use his privilege, that he is more likely to be believed by your provider. He is more likely to be, the symptoms are more likely to be taken seriously by the provider when they come from him, to ask him to be more involved in the medical process, so that that can be a great way to have an advocate at little to no cost, depending on missed work and things like that. And really asking people to utilize that privilege, to really like be heard. There's lots of different like paths to finding an advocate, like a more systemic advocate. That could be like some healthcare systems offer a patient advocate, a doula for the birth process. And doulas are amazing. I think that if you have the resources to go through birth with a doula, so wonderful, because they are going to be a lot more, in my experience, trauma informed around making sure that you have consent, that you have information about what's happening to your body and what the level of risk currently is. I really find that doulas can make all the difference. So I really, really recommend, if it's a financial option.
No, that's very helpful. And Tiffany, I have a few, but I want to make sure you get to ask your questions as well. So if you have anything else, I want to turn it to you.
Yeah, something that came up to me as you were talking about same-sex marriage no, my brain is working faster than I want it to. Talking about heterosexual marriages and struggles with infertility. I'm curious, have you ever come across like the same-sex marriages? Like, is that struggle with infertility different than like what you've seen in heterosexual marriages or like even partnerships?
Yeah, I mean, I do find that this is like, if we know that women are less likely to believe their symptoms, their pain levels, and then you add in the intersectionality of like their sexual orientation, we know that there's going to be more discrimination, more prejudice. Also, I will say I've seen a variety of things, because a lot of same-sex couples that have the resources to be able to go through fertility treatments to grow their family also have resources for things like a doula, or for really finding care that feels very safe to them. So I do find that in those situations, there can be a lot more positive outcomes, because there's a lot more resources. Of course, in our society, fewer resources probably means that unless there's like an intentional effort made, they may have a worse outcome. Very, very unfortunately.
Some of the questions I have are more for like maybe the people adjacent to those kind of having that lived experience, if that's okay. But I think definitely today the focus on like those with that lived experience going through. I will be honest, Tiffany and I have tried to do some searches, and we have found some of the information for like family members or partners, like it's kind of choppy, and I don't mean to say that like in a disrespect, but it's like trying to get all the information like you're presenting it today. Like I think this is just I'm learning things even as we are talking. Like, do you think like there's a best practice or like effective ways as like a partner, friend, family to just address the healthcare trauma of that experience of infertility? Is there anything you would think? I know it's very hard to do this every time, but is there a general kind of, hey, this would be the general way of trying to approach that conversation you would suggest?
Yeah. So if all the things we've talked about that have been very traumatizing for women in the healthcare system have been like not being heard and not being believed, for a partner, for a friend, I would say hear them and believe them, right? Like really having this conversation about asking what your partner needs, asking what your friend needs right now, empathizing with them, just simply like, I'm here and this sucks and it's unfair, and not trying to minimize or make it better, finding the bright side. Like, no, we don't need to find the bright side in this situation. This is a grief situation. And then also really just being there to like believe women. If you know, if your partner or your friend says, you know, the doctor said this and it felt really invalidating. Yeah, I bet that would be invalidating. Like, really, there's sometimes in cisgendered relationships and like heterosexual relationships, a trend sometimes I've noticed of like partners feeling the need to problem solve. And I think it comes from a really kind place, a place of like, I want to make this better. But what it really can feel like is a lot of invalidation. So when I work with, you know, I don't really work with couples anymore, but like when I work with women and I'm talking about like how to communicate to a partner, a lot of like clarifying, is this a emotion conversation or is this a fixing conversation? Really allowing partners to know like we don't generally need you to be fixing this because it's outside of your scope. You can't fix this. But really asking like, I just need you to be there and believe me and hear me. To really not try to not re-traumatize.
Man, so helpful. Tiffany, I got a few more. Are you okay if I ask a few more?
Yeah, go.
Okay.
I'm absorbing.
No, I know some of these Tiffany and I came with together, but what are the things for individuals who maybe not experienced infertility or IVF, like should not be asking or doing? Like I know it's a very zoomed out question, but like what are the like
Yeah.
maybe do's and don'ts of like trying to support someone going through that experience if you have not gone through that experience
Yeah.
or understand it?
Well, from like a very zoomed out lens, I really think that culturally we're on a good track in this very specific way of
Mm,
making it more taboo to ask people about their reproductive future and their plans and all those things. Like
mm,
that it's no longer, I think it really is to our benefit, whether we've experienced any sort of infertility or reproductive challenges or not, to not make it so common to ask people, are you going to have kids? When are you going to have kids? Are you going to have another one? Because those
mm,
questions can be so rife with pain, heartbreak, and also, to be frank, it's no one's business, right? Like what someone is planning to do with their family, because that comes into things like your mental health and your finances and all of those things that you may not be willing to talk to with Aunt Susan at Thanksgiving. So really, I think as we remove those conversations from the norms, I think that's a really great way to make this more protected. Now, if you do have a friend that you know is struggling, or you have a friend that you know is going through this, again, asking, like, I think is so powerful. Asking, like, making it clear, this doesn't make me uncomfortable to talk about. And I want to make sure that we're talking about it and I'm there for you in the way that you need me to be. Are you okay if I ask questions? Do you want me to check in? You know, I'd love to do some things for you. What do you need right now? Like really asking those questions rather than what people often feel the need to do. And I think it can be hard even as a therapist is wanting to rush in and fix because we want to make people feel better. So often there can be an inclination for when you're talking to a friend with infertility to be like, let's, find the bright side, or, I want to tell you about this person that I knew that was going through what you went through, and they now have a happy, healthy baby. That doesn't feel good to someone who is experiencing infertility, right? This idea of like, oh, this other person had a success. Great, that person's not me. And that doesn't necessarily feel good or empowering. And really recognizing that, like, as much as it's coming from a place of wanting to make someone feel better, that centering your own emotions in this interaction of like, I want you to feel good. I want me to feel better about this interaction because I was able to offer some like wisdom or something good is not going to feel good for the person going through this. I think truly just
it's
this
just so well
sucks.
said.
Oh, thank you. Well, I think truly just this sucks. I hate this for you. It's unfair. Like that is just like the method, like the messaging that we give in grief therapy, right? All the time as therapists, and recognizing that this truly is a grief issue.
Yeah, it's about you're making it about you at that point when you're trying
Yes.
to, oh, it gets this or don't give, it's like that's about you. It's not about that person. And I think that's
Yes.
really shameful that if you're
Yeah.
trying to make it about you for someone that's going through a trauma, I'm like,
Yeah.
that's pretty rough. Tiffany, I
Yes.
look like you may have had something.
Yeah, I just had essentially two little plug points to go with what Hannah was saying. Like, there's that part of like where society has made it so, maybe the word is unacceptable to just say, oh, that sucks, and to like encourage people to sit in the fact that emotions really fucking suck.
Yes, yeah.
And we've gone into masking and doing this little play, so to speak, of like, let me just say, like, let me just do more journey comparison, and so and so's journey like turned out fine, and your journey will turn out fine. Just kind of that like unintentional like putting down of like, well, I feel better that I don't have to sit in this emotion with you, and so got through it, so like you'll be fine. And it's like, well, maybe, but also like I don't give a shit if I'm fine. I just want to sit here in it with somebody.
Right. Yeah. And really just like being someone that can just sit in that discomfort is such an uncomfortable place for us to be as humans. But recognizing when we're like sacrificing our own comfort, that's one of the like most authentic gifts we can give someone, an authentic like gift of our presence. Because a lot of people, they feel so isolated on this journey by the fact that they are alone, like in their body, but then also in the fact that like they can't have a conversation with many people in their lives, including often their partners, that feels like we're just sitting there and feeling this together, which I think is one of the like biggest tragedies of this.
Yeah.
Just throw a plug of like, don't ask how someone's doing related to this, or check in if you're not actually going to hold space for it. I think we could say that for a lot of different situations, but that is so much more damaging than just not asking at all, or even being aloof and distant.
Yes.
I got two more questions because and I really think you're qualified to answer them. One is, what do you recommend to people who are posting about children or pregnancy announcements on social media? Like, what do you, any like, I mean, I'm not trying to make you the authority on all things, but like, what do you think about that? Is there a way where people can do that in a trauma-informed way? If you think so, I'm just curious.
So that is a question I'm going to make my intro a little bit longer so I can think about it. But like,
Yeah.
I think that's a hard one. I mean, one thing I think is challenging is when you're posting on social media, you're potentially posting to like 300 for, however many people that you have no idea what they're going through. And I do think there's an element of you can't be responsible for everyone else's emotional experience. Like, I think there's also an element here of like making sure that you're not taking on too much responsibility. But if you also have people in your close like network um, that you know are going through this, I think having a conversation ahead of time, a conversation that's empathetic and kind, and often not face to face. I know it can feel cruel to do something like this over the phone or through text, but allowing them to have space where they're not having to care for your emotional reaction. Like if you're like telling a friend who's going through infertility, I'm pregnant, um, like over text sometimes can be the kindest way because then they can have whatever reaction they need to have, and like then they're not caring for your emotions of like, I'm so happy for you, but I'm just sobbing because of this, is like
Yeah.
doing my own, that your friend is happy for you or is there whatever they can be right now, but maybe they just can't have that. I think that one thing I try to do for a lot of my infertility clients is really look at what are those places that where you can be triggered. And for many clients with infertility, social media is just such a negative place to be because people are going to post about kids, people are going to post about pregnancy. And I do think it's really hard. That's one of the negative sides of social media is like you're being exposed to all these details of people's lives that maybe it's like Kevin from high school and you haven't talked to Kevin in 15 years, but it's painful to see his girlfriend's pregnancy announcement or his partners like they're posting pictures of their kids. So really identifying like, is this helping or hurting you?
I think that's a fantastic answer. I don't know if I would have been able to answer it as well as you just did, even if I had prepped. The last thing I have is just because I know we've talked about the expense of like IVF and some of the other treatment options. Do you have any suggestions for maybe someone who doesn't have as much access to funds and is looking to like get some supports or resources? Like any suggestions of where someone could start that like research for themselves?
Yeah, so I did actually make a list of things that I thought like low resource ways to educate yourself around women's physical health. I don't have resources specifically around actually there is it's Two Queens Birth Doula website or Birth Doula podcast. I think that can be a really great resource, but podcasts are if you're listening to this, then you're probably someone that likes podcasts in general. Maintenance phase is really great for learning more about like fat phobia and body shaming in like wellness trends in our medical system. Two Queens, I think it's called Birth Doula, is great for learning more about birth and like the fertility process. And then I really like on Instagram, she's called the PCOS nutritionist, and she has a course about like how to care for yourself while having PCOS in a completely anti-diet, anti-restrictive eating way, because diets and restrictive eating don't work. And I want to make that plug there, that if any doctor is saying that that is the solution, we know that diets have a 99% failure rate. And is it really ethical to propose something that like isn't going to work for your client? I think that's important to really like have that conversation. So those are 3 resources that are fairly low resource or free, that I think are really great starting points for learning more about how this can, like how your health can be impacted by all these different systems.
Wow. Well, Hannah, you've given us just so much information, so many great resources. I want
Yeah.
to make sure, is there anything that we've not asked you today or anything else that you wanted to discuss? I know we've covered so much today.
I can't think of anything but I could go on talking about this forever and ever. But I can't think of anything off the top of my head, but I really love getting to really dive into this because I'm so passionate about it and the ways that our systems are so inequitable and don't always care for women in the way that they deserve. But I do think, I will just maybe reemphasize the point that if any of these feelings of like, I'm not good enough, something's wrong with me, my needs don't matter, those feelings are coming up in the healthcare system, there's often a root to it in earlier traumas, and it can be a trauma of omission, like not getting the attunement and the learning the emotional regulation from your parents. And it can also be traumas of commission, so abuse and things like that. Really recognizing that there's a lot of things that can impact the way you show up in the medical system and the way you're impacted as a patient. Not to put any blame or shame, but to recognize it can like trigger us differently.
Mm-hmm. Yeah. I don't know if you have any other questions, Eric or Hannah.
Nope. I honestly, I want to say like this is such a important topic. This is one that Tiffany and I have wanted to discuss on the podcast. So, Hannah, I just want to thank you because we honestly were like, unless there is an actual expert coming on, we just both were like, this is not one we feel comfortable getting into all the nuances on. So I just want to thank you again for your time. And I just want to plug Hannah myself, like Hannah Smith, like counseling. Like if you are looking for support in some of these areas, she is based in Cincinnati and would be an option if you're looking for a therapist in this area. But Hannah, just thank you so much. I hope we can have you back and have some of those resources. But thank you. I really know I've learned so much in this conversation, and I won't speak for you, Tiffany, but I feel a little more educated on this.
Yeah, I definitely feel more educated, and I definitely feel like there's a lot to this area to learn.
Yeah.
But I think Hannah has really kind of helped us like see more of maybe what we weren't aware of, like regarding this topic. And I appreciate the information and the conversation that we've had today.
Well, thank you so much for having me. I really, really appreciate it. It was so great to get to talk to you all, and I can't wait to keep listening to the podcast because I am always listening to a podcast when I'm not in session.
Gotta have something, right?
Yeah. With that being said, please, everyone listening, please feel free to join us on Patreon. Free to join. We do have some cool things happening in the works if you want to check it out. We're also on Spotify, Apple Music, I think Amazon Music as well.
Thanks for tuning in to this week's episode of Deciphering Growth. We hope you found our conversation helpful and insightful. Subscribe to our podcast for more episodes and check out our Patreon for more content. Don't hesitate to contact us on social media if you have any questions or comments. We'd love to hear from you. Until next time, keep growing.